All right, so Steve asked me to talk about fistulas, spinal and cranial, and I have way too much to say, way more than you want to hear, and so I'm going to talk till I get bored. And I was going to talk firstly about intracranial fistulas, and if time allows, then we'll start with the spinal fistulas a little bit. I have a couple of acknowledgements. Philippe Albuquerque and I have been splitting the endovascular work for a long time now. A great partner, and we've worked well together. Brad Gross is a current fellow who put together some of the current numbers that we have for intracranial dural arteriovenous fistulas, and he based that on some work that Yin Hu, who's now at Case Western, had done for us some years back. So Brad updated the numbers for me. Move forward. There we go. So Onyx and NBCA for fistulas is off-label, and I have consulting agreements with EV3 and Microvention. So I'm going to keep this kind of a very sort of my simplistic view of it. And fistula is just an arteriovenous shunt, a dural fistula occurring within the dura. They occur in proximity to sinuses. Often the sinus is not visualized. It's either stenotic or completely obstructed. And the locations, the most common ones are transverse sigmoid, cavernous sinus. The indirect fissures there are dural arteriovenous fissures of the cavernous sinus, and that's probably the second most common location. But we see lots of them around the straight sinus and the tentorium, the sagittal sinus, around the torcular, the ethmoidal and the anterior cranial fossa, and around the foramen magnum, and they go by different names there. I know them as marginal sinuses in that area. Where they come from is controversial. You do see congenital dural fistulas. They're usually high flow, sort of bizarre things, often presenting with failure, and they can be multiple. But for the most part, they're an acquired lesion, usually in middle-aged and older adults. We think that the sort of common inciting feature is venous hypertension, often a sinus thrombosis, and Mike, when he was a resident, did some nice work creating an animal model of a dural arteriovenous fistula, which goes along with that. We definitely see them associated with trauma, with surgery, mastocytitis, sinusitis, different things. And this is just a nice kind of example of a 60-year-old guy who had this large meningioma that ultimately obstructed the sinus and went on to develop flow voids there, which proved, of course, to be fistula. He had high-risk venous drainage, cortical reflux, and all this edema, which is a little more than you would expect from the meningioma alone. And so the fistula was right in front of the tumor, supplied by middle meningeal arteries on both sides in the right and left frontal views. And then in the lateral views, again, it's recruited the superior temporal arteries and as well as the meningeal arteries, and quite a high flow, all going to veins there since the sinus was obscured. This one was embolized preoperatively. I couldn't get this one branch here, so it wasn't quite cured endovascularly. They are notorious at recurring if you don't 100% cure them. So he then had his meningioma resected, and that last little bit of the fistula was treated at the time the meningioma was resected pretty uneventfully. And this is a follow-up a year later, showing that there was no residual dural fistula. He did unfortunately go on to develop at 2 years some recurrent meningioma and had that resected and did well after that. So as I said, thrombosis may precede a dural fistula. That may incite enlargement of the normal microscopic arteriovenous shunts that exist within the walls of the sinus, and probably releases vasogenic factors that ultimately lead to the development of the fistula. There's a lot of classification systems. They're all sort of based on the same thing, and I'm more of a lumper than a splitter, and so I just think of them as either benign or malignant. And the patients that have benign venous drainage are presenting usually with tinnitus or maybe orbital symptoms, ocular motor palsies, sixth nerve palsies, proptosis, and the ones with aggressive symptoms are presenting with a really wide array of symptoms. They can hemorrhage, of course. They can come with seizures, altered mental status, hydrocephalus. They can present often with dementia-like syndromes, cranial nerve palsies, or motor symptoms. Sometimes you have to be concerned when you're following a fistula and the symptoms change, but in the benign group, it's really unusual for them to convert to become a high-risk fistula. And the Toronto group looked at that, and it was probably only about 2% of patients that they followed that originally presented with a benign profile of cortical drainage to turn into high-risk lesions. High-risk lesions, on the other hand, are bad. They are worse in terms of the natural history than unruptured aneurysms and worse than arteriovenous malformations. And they have a hemorrhage rate, depending on whose numbers you believe. The St. Louis group, WashU, said 8.1% hemorrhage rate and producing deficits at 6.9% annually. The Toronto numbers were higher than that, more like 10-15% hemorrhage per year. But it may be lower for symptomatic versus asymptomatic patients. Certainly, patients who are presenting symptomatically with a dural fistula, I think, needs to be treated. The disappearance of a noise, a lot of patients present with pulse synchronous bruit. If the noise goes away, and maybe the sinus has actually gone on to completely occlude, then it gets quieter, but the flow it's quiet because the flow is redirected intracranially. So I'm always paying attention if a patient tells me that the sound has changed, whether it's gotten louder or gotten quieter. Either one can be a change often to a more hazardous situation. And certainly you'll see lots of evolution of symptoms with cavernous fistulas, where some of those will close spontaneously. Proptosis and the visual symptoms will change with time, but most people aren't willing to follow those long enough because the symptoms are at least cosmetically troubling to the patients, if not painful, and double vision. Nobody likes that very much either. The angiographic finding that's most predictive of impending hemorrhage is cortical venous drainage with ectasias, and the ectasias occur because of stenosis of the vein. So if you've got a cortical draining vein that is arterialized and has a stenosis and starts to develop these ectasias, that is the single highest predictor of impending hemorrhage. So what are the indications for treatment? Well, number one, do the symptoms justify the risk? So if it's a low-risk fistula, no cortical venous drainage, are the symptoms disruptive enough to the patient to justify treating it? Number two, are there high-risk features, whether or not it's symptomatic? And I find that it's really unusual that partial treatment is helpful in any way. They just recur far too frequently for the partial treatment to be very helpful. In Phoenix, we looked at a 10-year experience with high-risk fistulas, so fistulas that had cortical venous drainage that were treated surgically from 1994 to 2004. And you can see the distribution, wide variety of locations of the fistulas. The indications for treatment were either hemorrhage or neurological deficit in 3/4 of the patients. There was embolization preoperatively in about half of this surgical group. And for the outcomes, you see that we had, in this not really that old a series, good outcomes in around 92% of the patients. Almost 10% of them were not cured. The morbidity was significant, with 13% morbidity and mortality, including 3 deaths. So not trivial for these high-risk lesions managed surgically. I'm going to talk now about the endovascular treatment and really how Onyx has changed our life in terms of dural fistulas, because it really has changed that. Onyx became available 2005, so we've got about a 10-year experience now with Onyx. We've looked at the endovascular treatment in Phoenix since I arrived there. We've got 260 dural fistulas. This is just the low risk versus the high risk types with the retrograde venous drainage in the 3s and 4s. And the treatment approach is usually a combination. And I don't really pay that much attention to whether it's transarterial or transvenous. You're really just looking at where is the fistula and what's the easiest way to get there. And if it's easier to go surgically, that's fine too. It's just where exactly is the fistula, what's the easiest way to get there. Over that entire experience, our obliteration rate is about 72% from endovascular alone. We've got an 8% complication rate, but only 3% of those were permanent complications. Brad put in a recurrence rate of 8%, and before this gets published, I'll be working on him on that, and we'll get that number down a fair bit. That's a joke. But I actually do think that he's defined recurrence a little bit different than I do, because I in the first place, don't consider these cured. They are evil lesions that are secreting vasogenic factors, and if there's even a little tiny bit left when you first treat them, they will come back. And so when I initially treat them, there are too many frustrated arteries and usually a lot of embolic material, and so it's very hard to see a small residual fistula if it's there. So I never consider them cured at that point, and I always bring them back at least 3 months later. And if there's no flow at that point, then I consider them cured. And by that time, you'll see really nice regression of all the enlarged arterial feeders that were there. That will all regress to normal, and it becomes very clear as to whether or not they're cured. So I think Brad is counting some of those patients that we brought back for follow-up, and counting some of those as recurrences, because if you get them to that 3-month or later period and you've seen regression of the feeding arteries and you're not seeing any fistulas, I have no recollection of any cases recurring after you've got that delayed confirmatory angiogram. So that's really the point that I evaluate them at, certainly not the initial time of treatment. You can be reasonably confident, but I just don't trust these fistulas to say they're cured at the initial time of treatment. If you look at our obliteration rates before and after Onyx, so this column is before Onyx and this column is after Onyx, you see a couple of things. Number one is that the overall obliteration rate is substantially higher, almost 80% versus 60%, but you see that the number of cases is almost twice as much as well. And what that really tells you is they're not the same cases. So I think our referral patterns, our volume of cases were pretty similar during the two periods, but during this first period, a lot of cases we just weren't taking on. I just didn't feel we could cure them with endovascular treatments alone, so a lot of the tentorial ones, some difficult access ones, all went to surgery, and now those all come to the endovascular suite for a first crack at. So we're treating a much higher percentage of them and having a significantly higher percentage of cures from treating them endovascularly. That's uninteresting. If you look at the different locations again, there is a fair bit of variety, range in our obliteration rate with endovascular techniques here. This is the obliteration rate for the different locations, the anterior fossa, the ethmoidal ones. Again, a small number. There's not very many of those we actually try to treat. I think most of those should go to surgery. I find the midline ones like the superior sagittal sinus and the torcular are particularly difficult to cure endovascularly, so the rates are a little lower there. But some places like the cavernous sinus, I think if you look at our numbers since Onyx, that number is probably quite a bit higher since Onyx has come along. There are some disadvantages to Onyx. So one we've heard alluded to earlier today, there can be long fluoroscopy times. You have to be very careful about non-target embolization, and Onyx is pretty expensive stuff. If you're using a large volume to sac, for example, a sigmoid sinus, can be a fair bit of Onyx, and I'll usually use something less expensive there. So when you guys are just looking at a case in the emergency room or a case referred in or whatever, you sort of should be running through your head, is this a dural fistula at all? Dural fistula versus arteriovenous malformation. If it's a fistula, where is a fistula? Is it single? Is it multiple? Does it need to be treated? How do I get there if I am going to treat it? And what do I do when I do get there? What do I treat it with? So those are sort of the questions, and we'll just sort of answer these questions sequentially. So the first thing, if you're looking, the initial image is often a CT scan, maybe a CT angiogram or MRA, and you see some flow voids, and the question is that an AVM or is it a dural fistula? Well, if it's a dural fistula, chances are that there's no discrete nidus, and that's the first thing that should tip you off. If it's a low-risk dural fistula, you won't see really any excess flow voids in the cortical area, since it's all going to be within the dura and the soft tissues. So is there a nidus? If you do see enlarged arteries, what's supplying it? AVMs obviously are PO vessels. Dural fistulas are meningeal, occipital, ascending pharyngeal arteries like that. AVMs will respect compartments. You won't see with any frequency at all, if ever, an AVM that extends from supratentorial to infratentorial. But dural fistulas, you will see the draining veins not respecting the compartments. And is it associated with a sinus or is it distant from a sinus? So those are sort of the tip-offs just on your initial screening image. Then comes to looking at where the fistula is. And this you really need to do from the angiogram, unless it's obvious, huge sigmoid sinus or a huge enlarged ophthalmic vein for a cavernous sinus fistula. It's often hard to tell exactly where the fistula is on any sort of axial or non-invasive imaging. And the image you should look at on the angiogram is the very first or second image with arterial flow on it, because you want to look for that very first place you see vein. If you look at the later phases, it can be overwhelming. Everything's contrast everywhere, and you really can't make heads or tails of it, except you can sort of maybe see which sinus it eventually drains to, but you really can't tell where the fistula is in there. So if you're doing common carotid artery injections, it's often very hard to know. So you'd like to have a nice super selective injection, because most of the time fistula is going to be at one place, and if you have a nice pedicle that you can super selectively catheterize, that's going to tell you where the fistula is, and just look for that very first flash of vein on the early arterial things. And if you check a couple of them and they're not all going to the same place, then you should really be thinking that perhaps there's more than one fistula. It's not uncommon for there to be a couple of fistula sites within a region, and that happens probably in about 10 or 15% of cases. There's actually more than one fistula. So the next question on the list was, does it need to be treated? And I already mentioned that, is the patient symptomatic, and are there high-risk features? And those are really the two things that push you one way or the other. How do I get there? Endovascularly, the middle meningeal. I'm always looking for the middle meningeal artery because it's a nice, straight, easy shot, easy to get into. It's safe. The collaterals from it are somewhat more consistent, manageable, and avoidable, particularly if you're looking at fistulas that are located back in the transverse sinus around the tentorium. It's all sort of free lunch back there. There's really very little you can hurt. So the meningeal artery is really nice, whereas for the fistulas in the same location, if you're working off an occipital artery, you have to get that onyx from the occipital artery in the scalp somehow through the scalp, and then usually a fair distance to actually get to the fistula. So the occipital artery is often much harder. If there isn't an arterial road there, then is there a nice venous pathway to get there? That's often straightforward. We used to do a fair number of direct punctures, a little burr hole over the transverse sinus in the operating room. I haven't done a direct puncture except for a carotid cavernous fistula for a very long time. And often we used to combine therapies. When you do get there, do you need to close a sinus or can you preserve it? And then what agents are you going to use? Or are you going to use solid agents like coils or particulates? Can't think of a role for particulate agents. It's just to hide the fistula for a little while till it recurs and is more difficult to access. So that's rare. So we'll just look at some cases now and go through it. And this is a 66-year-old woman who presented with a pulse synchronous bruit. She wasn't that symptomatic by it, wasn't troubled by it that much, but we wanted to do an angiogram, recommended an angiogram to her to look for high-risk features, and certainly everybody that I see gets an angiogram to make sure there are no high-risk features, even if their symptoms are mild. And so this was her angiogram. High risk or low risk, anybody? Arterial in the late venous phase, lateral view, common carotid artery. That's low risk. We're not seeing any abnormal veins here. So we've got the sinus fills here. We have no veins in the early phase, no cortical veins in the early phase. So if it's high risk, you'd already be seeing those dangerous veins. So this lady, as I said, her symptoms were mild. She's got no high risk features. We left her alone. And 4 years later, she came back, and this is just showing she's got a little bit of hypoplastic sinus there in the PA view, but really nothing concerning at all. 4 years later, she came back and said, it got quiet. I don't hear my bruit anymore, and I'm having headaches quite a bit. And we angioed her just to make sure it hadn't converted to be a high-risk feature. And this is what we found. She'd actually gone on to thrombosis. She cured herself, and she ultimately did well, and her headache settled down. All right, so this is a guy. He's 70 years old, left common frontal, left common lateral. High risk or low risk? He's presenting with cognitive decline. I heard some murmurs of high risk. If his cognitive decline is actually due to the fistula, by pretty much you don't even need the angiogram to know it's high risk if he's got nothing else going on, but of course you don't know that. But you can certainly see here he's got retrograde filling of veins there, and this is a high risk fistula. The selective injection of the occipital artery, this is a lateral view, this is the early phase. So this is nice because in this early lateral phase, you see fistula right there, and it turns out on the later view, and the contrast gets up, you actually have shunting up here as well. But now you're also seeing, what's all this stuff? That's all reflux, that's all cortical veins. You've injected the occipital artery, and you're seeing all of his cortical veins light up. You should never see cortical veins filling from an occipital artery injection unless you've somehow collateralized to the vert or something. So this is a high-risk fistula, actually two fistulas there and there, separate fistulas. And this is showing the second one now. This is a lateral view. This is the middle meningeal, filling that second fistula there. So the occipital artery fills one low and one high. Probably some single unifying thing that affected that whole transverse sigmoid sinus thrombosis, developed fistulas at a couple of locations, but they're kind of compartmentalized, so you have to treat them separately as two fistulas. And whether you actually want to call it two fistulas or one is just semantics, but there's two sites there. So the middle meningeal allowed us to get to that one, and then the separate approach to the occipital for that one. And this lady's dementia, improved very well. She had a very benign course. But what you don't really see is resolution of sort of the congestion of the cortical veins. So even years later, if you do an angiogram, they've lost some of their venous outflow, and you'll often see that there continues to be congestion in the cortical veins, but it seems to be pretty well tolerated. All right, so this is a case I showed just so that people don't annoy me. It's a man who has a fistula in the midline, but somebody embolizes occipital artery here. So the fistula's way over here, and the point of this is you have to get to the fistula. Putting anything in the arteries that far away from the fistula is just going to obstruct your access to get to the fistula later. So don't burn bridges in your treatment. Make sure you get to the fistula or leave it alone, find another approach, find another way to get to it. So this is showing the microcatheter through the middle meningeal, had to come all the way around the back, and there's the tip of the catheter there in the frontal view, and here in the lateral view. And then when you inject that, you see the fistula there. So that's the kind of picture you need to have as your immediate pre-embolization picture to know that you're going to be able to treat the fistula. If you can't get a picture like that, then you're likely going to fail in your treatment. And this is what the cast of Onyx looks like in the midline, and the fistula's gone. So this is another case sort of showing that what it actually looks like more in real time, since I've more recently been able to capture actual videos a little bit. If they'll play. Oops, let's go back. So this is obviously frontal and lateral view, carotid injection. And this is a guy he's declining cognitively as well. He's having a lot of trouble, high-level business guy. But you see here in the late phase, incredible venous congestion. and no sagittal sinus. And you saw a little bit of reflux on that first image to the occipital artery, and this is what the occipital artery looks like, or the external carotid artery looks like when you inject it. Where's my, let's get that back here. So in the early phase, just like I paid you. Excellent. So the we want to go to that early arterial phase to see where the fistula is. As you saw later in the run, it becomes just one big blur of veins and you really can't tell what's going on. But here you've got, first of all, this is the lateral view, remember? And you've got enlarged tortuous middle meningeal all going back, way back to here, and the fistula's back here. And if I can get it to go just a little bit further forward in the frontal view, right. Sorry, I'm just having trouble controlling the slider here. Come back. There. So now you can see the very first vein is right there. This is the middle meningeal in the frontal view coming around right to the fistula there, and everything leads to this point right here. So the fistula's here, this large cortical vein that then extends up all the way up here, and everything that's to all these cortical veins there as we go on. Okay? And the sinus itself is out. So that's the key thing, is to locate the fistula, and then after that it's pretty straightforward. So I showed you the internal. This is the catheter manipulation. I'm really messing up on my arrows here. That's the one I want. Catheter here is being manipulated. This is a little bit tortuous. I wasn't sure we were going to get through that. But once you get through this segment here and you get onto the straight part, it's pretty clear sailing all the way to the back into this fistula. I don't know if you can see that or not. Now we're there. We're away to the races there now. So at that point, you're set up. Your microcatheter is here in the frontal view. I can't quite see it there in the lateral view. And on the other screens, we have set up our monitors so we know what it's supposed to look like. We want to get the Onyx into this area. We do the microcatheter run. And there, you're right at the fistula. Okay, so the catheter is right there, right at the fistula, right there in the frontal view, matching these points. So, it's easy once you know where the fistula is and getting there. And this is the Onyx injection here. It only goes on for about half an hour, so we probably won't play the whole thing. I'm just going to jump forward through it. You just have to be a little bit patient.
So, question there, Cameron. The fistula's point looks pretty focal, but almost always needing to inject so much goop in there. Why do you think that's the case?
I'll show you that a little bit on this one. That isn't the case, I don't think. I mean, if you're in the right spot.
You were there. I mean, you were in a perfect spot there.
But it's a big vein. I mean, that is a big vein, and you have to occlude that vein. And Onyx is bad because, as you talked about it flowing like lava, there's often lava tubes in there. So there's hollow areas in the middle. It'll coat all around, and there'll still be flow through the middle. And if I can find it on this slide, I'll show you what's some of that. Because we're stopping every once in a while and taking pictures.
What about something like one of those new plugs they have?
There, this one right there. So we've got a fair bit of Onyx in there. The Onyx is nicely in the vein, and you can see in the two frontal views, and you can see in the unsubtracted how much onyx is there already. And when you inject the common carotid artery, you still see this branch still filling it. So we haven't completely plugged that vein yet. So we got to keep going until that vein is plugged, and that's the real key point. If Michael was there, or like this guy's surgeon somewhere else wanted to open that surgically and put a clip there, that would be fine. It's just that it would be a pretty unpleasant opening because he's got so much, vascularization of the occipital bone and things like that. It would be fairly miserable. But one clip across that vein would take care of it. So at this point, we know it looked like we thought we had enough onyx in the vein to be done, but we weren't actually done because when we did the run, we saw that, and you just keep injecting, and you get to the point where I think it's on this clip. If you keep going, you'll see that what happens is the onyx starts to reflux to those other arteries. So then you get this sort of starburst appearance. Once the vein is sealed, now you start filling all of the arteries that supplied it, and you end up with this sort of starburst where you're getting from the arterial injection through to the vein to the collateral artery supplying the fistula. And so that's what it looks like in the end. So whether you think that's a lot of onyx or not depends on whether you're selling onyx. It was one vial, but one other trick to sort of get the onyx to the target, if you can't get as close, is some of you may have heard of René Chapeau. He's a pretty good interventionalist in Germany, and he's developed what he calls his pressure cooker technique, which is kind of fun. And this is a lady that I had partially treated in a weak moment to palliate. I had chickened out because if you look, the fistula is here in this lateral common carotid artery injection, and her labia was pretty close there. So she was a low risk, and it was just noise. So I palliated it, which again is a mistake. But she came back and said that, she really was unhappy with the noise and wanted us to try and treat it. So we're going to try and cure it now. But I didn't want to close off that sinus because it's so close to the labia. I wanted to get this transarterially. She had a little additional fistula site down lower. So I wanted to get to that arterially, but it was difficult to get a catheter close enough there. So this pressure cooker technique is something that we use. And the first thing you do, sorry, I need to go back, is we put two catheters into that middle meningeal. So this middle meningeal is going to supply this fistula here. We put two catheters into that, an Apollo with a detachable tip distally and a little echelon proximally. And then, did I jump by it? And this is NBCA being injected, frontal lateral view. The NBCA is being injected proximal to the tip of the distal catheter. So we're in the middle meningeal. Onyx, the NBCA is going here, and we just want to put a plug there. Instead of trying to build your plug with Onyx and taking half an hour of fluoro time, you can just completely seal the artery right behind the markers of the Apollo. So the Apollo catheter is downstream here. The NBCA is put in there. And then when you go there's the NBCA plug. Here's the Apollo catheter. This is some previous embolic. And then you can just inject that with impunity without worrying about having any reflux.
I thought the pressure thing, he did something with that Copernicus balloon. Or does he put that in the sinus as well?
The Copernicus was to protect the sinus itself, and then to embolize that. But the pressure cooker is actually sort of sealing the artery and having the second catheter more distal, so there's no reflux. And so this is with that middle meningeal sealed. This is the location of the Apollo catheter that will detach, and then you can
when it goes into the sinus.
pretty quickly put in the Onyx. That's the roadmap for where we want the Onyx to go. And this is the whole Onyx injection. This isn't edited or cut. This is the whole thing. And you see that's the catheter. There's no reflux there, but you can just keep going and not have to build a plug. Normally by now you'd be stopping and waiting and building a plug and having patients, which is really boring. I think I'm out of time.